Okay. Okay, we are now live. All right. Hello, everybody. Today is Saturday, 9/5/2000, and it's 3 o'clock. We're here with our COVID-19 Frontliners from the Philippine Medical Association of Hawaii. My name is Dr. Morel Ver, and I will be your host for today. And I just wanted to let you know about the PMAH. We are a network of Filipino and non-Filipino doctors taking care of Hawaii's community. We've been around since 1978. The goal of PMAH is to educate our community about our community by our local doctors. And we want to raise awareness of what's important out there. And right now, COVID-19 is a hot topic, and many of us PMAH physicians are frontliners. Our last Facebook on August 22nd, we spoke to Drs. Ganitano, Dr. Valdez, and Dr. Klein about what it's like to work in Hawaii's hospitals. But now I want to spin it a little bit and get another perspective on COVID-19. Our goal today is to learn about non-hospital care with special regards to COVID-19 patients. And a disclaimer, I must say, these are opinions of our own, not representing any one major hospital system. Just some housekeeping on our Facebook Live chat room. We are collecting comments and questions, and we will try to answer your questions by the end of this event. So thank you very much. All right. Okay, let's get started, guys. First up, we have Dr. Lyla Prather. Can you wave for me? That's Lyla Prather. She is hailing from Kalihi, went to Punahou schools, went to USC, also did a little bit of law school, I understand, and did her training at JABSOM and then UH. She is private practice internal medicine in Kalihi and Waipahu. Welcome, welcome. And next we have Dr. Hazel Abinsay, gonna wait for us. Also hailing from Kalihi, went to Sacred Hearts and JABSOM for medical school, USC for her training, and she is currently in private practice in Eva Beach in Kalihi. And lastly, we have this token white guy for this show. We have Dr. James Ireland, a very good friend of PMAH. He is a nephrologist. Originally from California, came to Hawaii at 19 years old, currently a provider in Eva Beach and Kalihi, and also helps out with the state task forces on COVID-19. So welcome. He is an inpatient and outpatient provider. Okay, now let's just get started on everything. Basics. At last Facebook Live, you talked about that all doctors are not created equal. We are different specialties, although we do have an MD to our name. So we are experts in different things depending on our specialty. Last session, we talked to an intensivist. They work in the ICU, and the hospitalists, which were the doctors that take care of hospital patients. So now you guys are different specialists. What does outpatient mean, and what type of doctor are you? Who wants to go first?
I'll go.
I can go first. We'll start with the kids.
Oh, go ahead. Let's start with the kids then. Do it.
For the kids. So my name is Hazel Abinsay. I'm a pediatrician. So I take care of babies all the way from when they get discharged from the hospital. So I see them as early as 2 to 3 days old. And then we can go up to 21 years old. So we see them through their baby years, toddler, preteen, teenage, early young adulthood. And so basically being outpatient for me means whenever a child is sick and needs to go see their pediatrician in the clinic, or if they need checkups, or if they need to have vaccines, or if the teenagers need any sports physicals, I see them in my clinic. I do not go into the hospital.
Dr. Prather?
So I'm an internal medicine specialist. So internal medicine is basically adult diseases. So usually a patient will graduate from Hazel's care into my care or one of my colleagues' care to handle things from age 12 all the way, 12's the youngest. I think I do 4 sports physicals on the 12-year-olds. But usually we start at 18 for physical exams, general maintenance, routine care, and then just filtering out to specialists if they need it, all the way up until geriatrics.
And what exactly is geriatrics again?
Geriatrics is elderly medicine. So if you have someone who's older, or it could be a young person with comorbidities that put them in a category where they need more help, then you see a geriatrician, which is for older medicine, where you can get a lot of social services and home care and things like that.
Okay, great. Dr. Ireland, you are a specialist. What exactly is a nephrologist?
Well, after medical school, to become a nephrologist, you first have to do 3 years of internal medicine training. And so I was an intern and a resident in the hospitals at St. Francis and Queens and Kuakini as part of the UH residency system. And Dr. Ganitano was on this program in the past, and I were interns and residents together. And I think one of those months, Dr. Prather was with us on one of our hospital teams. So got to really work well and with a lot of the doctors here that are internists. But then after internal medicine, I went for an additional 3 years of training in nephrology, and they don't offer that in Hawaii. So I had to go to the mainland for that. And I did 3 years of training in nephrology, which is the kidney. And we take care of patients with kidney problems, high blood pressure. And then if the kidney fails, we help patients with dialysis, cleaning the blood, and help them navigate the process of a kidney transplant. The actual transplant is done by the surgeon, but we take care of the patients before and after. So as a nephrologist, I take care of patients basically with issues with their kidney.
Great, great. So all of you have see patients in an outpatient setting, so outside clinic, outside of the hospital. Can you tell us how COVID has affected your practices?
You know, in the nephrology world, we notice, well, let me back up. Because I do some work with the state and a little bit of work with the lieutenant governor, I've been on some task force, and at the airport, we were paying attention to COVID as early as January 7th and knew that it wasn't even called COVID back then, it was called other things. But I was aware that it could come to Hawaii and started getting a little more worried along with the other doctors as February into March and April, and we saw more cases. And really what I felt was prudent to do, at least initially, was to change most of our clinic visits to video as in the outpatient setting as much as possible. And just because at that time we, in the beginning of all this, didn't have enough PPE for everybody, didn't fully understand how this was transmitted. And so our practice went to video, and that's kind of the initial major change that we did in the outpatient setting.
How about you, Dr. Prather and Dr. Abinsay?
So basically the same thing. Mainly we would see normally patients in the clinic face-to-face and do our exams hands-on, but we've gone to telemedicine for a lot of our visits, mostly for the patient safety, because we have a lot of patients that are high risk, like our asthmatics in Hazel's practice, and our patients that are like 65 and up and have other chronic conditions in my practice. So it's really not safe for them to be going around and being around other people that are sick in case the other sick people have COVID. So telemedicine is a big thing. We don't have patients in the clinic in the waiting rooms more than 2 people at a time. A lot of times people have to come in and wait in their cars. We call them in one at a time so that we limit the contact in the clinic. It's very important for safety for us as well as for the patients.
Hazel, how about you and the kids?
So I think I can speak for a lot of primary care, older primary docs, where our clinics used to be very walk-in heavy. A lot of our internal medicine, family practice doctors, even Filipino pediatricians, the Filipino culture for physicians was, everyone come on in whenever you can, we'll take you, don't worry, we won't turn you away. But when COVID hit, that was definitely not safe. We used to have kids who would, and families would be willing to wait in the waiting room for an hour, 2 hours to be seen, but in the setting of COVID, that was just definitely not safe. So we made this big switch to making sure that everyone has an appointment and no more walking in. And this goes for almost all or a lot of the Filipino physicians now, for our safety and for the safety of our patients. So for the patients out there and the families out there that are watching, thank you so much for being patient with all of our practices as we switched over to this new way of practicing medicine. But our patients have done really well with the adjusting that all of our clinics have done with our scheduling, we've also had a huge decrease in the amount of patients that we've seen in clinics. So in pediatrics, we're only now seeing the healthy children doing their well child checkups, and we're doing pretty much almost 100% telehealth for all the sick visits, which is a little bit difficult in pediatrics because a lot of times you need to see the ears, you need to see that throat, you need to listen to those lungs. So sometimes we will bring very few in. For the most part, we're doing a lot of telehealth, well childs only for the healthy kids. But even then, a lot of our parents are still very afraid to come into clinics. So our amount of well childs has gone down. And we've seen a lot of families and kids getting behind with their vaccines, which is a really big concern for us.
So most of us know what how these televisits are because we've used them, but there's a significant portion of patients who don't know what telemedicine is. I just got a question from the audience. What is telemedicine?
It's an appointment with your primary care physician or another doctor, and maybe a specialist like Jim or your cardiologist that's not in person. So oftentimes we can triage, and really 80% of your clinical exam as a doctor is about listening and trusting your gut and asking the right questions. Before you even put your hands on a patient, you're able to diagnose or at least get a differential diagnosis, like things that might be happening to the patient before you even see them. So as a clinician, you have to really trust your gut and your investigative abilities and your ability to bring out what's going on in the patient through the video. So you'd see me on the computer like this, and we'd have a conversation. And oftentimes our visits are longer than if you were here because I have to know more about you and I have to know more about what's going on, more details. So a lot of times we're spending even more time with the patients.
And then just to add, it involves maybe getting a text linked on their phone, right? Their phone, you press accept, enable video, enable camera, enable speaker, and then people get to have a Zoom chat like this on their phone with their provider. Yeah. Okay.
I just wanted to add one thing about, I wanted to just add one thing about this telemedicine and video visits. Prior to COVID, I had never done one visit over the phone or over Zoom. Now, part of the reason for that was the federal government and others had a lot of rules about secure phone lines and security, and it made it actually too difficult, in my opinion, to set up a lot of this stuff. But when COVID came and the government realized that we really did need to see our patients emergently by video, they waived a lot of the rules under these things called HIPAA and other things, which made it even easier to see people, even on a smartphone. And sometimes if I can't use the computer like I'm doing today for this Facebook Live with a patient, we'll just go smartphone to smartphone and we'll do the visit that way. So the government actually helped us in a way by changing their rules to make it easier to do this. Having said that, now that we are doing this, some people are saying to me, hey, I want to do this forever. I never want to come in because it's a hassle, it's far, you park and you wait. And that remains to be seen, I think, whether or not this will go beyond COVID. I think you do need to put your hands on people and examine them in person sometimes. But for a lot of visits, this could be a future trend that we see far beyond COVID, because it is easier for the patient for sure.
And I think especially for a community as well, a lot of my patients, and I know a lot of your patients, work multiple jobs. So multiple part-time jobs, they're working 7 days a week. Their schedules do not really accommodate the time to come in and see a doctor. And a lot of times they don't have sick time because they work multiple part-time jobs. So this has actually allowed me to see patients that I haven't seen for a few years. And they have questions which they're able to come in during business hours. So I sometimes stay late, 6 or 7, and can take calls when the patient comes, has to do it after work. Or other times I'll come in early or I'll do it during our lunch hour. So it's offered us a lot more flexibility and the opportunity for people to come back and get their health checked and their labs ordered when they haven't been able to come in for a long time.
And just to piggyback on everything that Dr. Prather and Dr. Ireland is saying is, when we did start doing telehealth in the beginning around March and April, it was new for us. It was new for the parents. It was new for the patients. So a lot of people weren't sure how to log on to platforms such as Doxy.me and Zoom. And so exactly what Dr. Ireland was saying, thank goodness that the government allowed us to use FaceTime and Skype And that allowed, and a lot of our families have those already on their phones. So that made FaceTime, or excuse me, telehealth a lot easier for us. But for those patients that are not necessarily technologically savvy yet, we do rely on their family members, the younger ones, their grandchildren, their children, to help their older parents get on to telehealth in order for this to work, to keep them safe.
And also as a specialist, I do, weight loss surgery, bariatric surgery, and it's really helped my practice in a way where many of our patients can now see the dietitians and the psychiatrists and myself very quickly and have more availability. Also, because I'm one of the specialists that are not many of us in the state, I'm able to have medical appointments with people from their home in Kauai, and there are people from their home in Hilo. And also, as a busy surgeon, I run around all day and I'm often late, and I can call my patients at 7 o'clock at night and they're totally okay with it, because and I still complete that visit at weird hours. Not that you guys work past 5 p.m., but I work weird hours. But so it's really been helpful in our practices. Okay, great. Okay, here's a question that's a problem maybe for telehealth. All of us here do not speak fluent Tagalog or Ilocano or Visayan. How do you communicate with your patients who speak different languages? In person and in the setting of telehealth?
For me, we have other people in our office who speak different dialects. The nephrologist with me, Win Mo, she speaks Burmese and Mandarin herself, and so she obviously will take patients who are Mandarin speaking. For the other dialects, there are people in my office. There's practitioners who speak actually Japanese and others who speak other dialects, including Ilocano, Visayan, and Tagalog. So we'll just get help with the medical staff within the office for me, or we enlist family members on the other end of the phone or video to help with their mom or their brother, or sister, or dad, or what have you. The other thing I wanted to say earlier, and I kind of skipped my mind, is we also had this quick learning curve of like which program we wanted to use, and we found the DoxyMe worked well for our clinic, and patients had a little harder time with Zoom, even though I use Zoom for most of my meetings and other things when we need to do a video like this one. But the good old smartphone is good enough if we don't have that. And unfortunately, if all of that fails, we just use the telephone.
Right.
Technically, it's a little different and the billing's a little different.
So how about you, Lyla and Hazel, within your practice about the language?
Same. I have a staff that supports me that's really good at helping me with Ilocano and Tagalog speaking patients. I grew up with my mom and dad and my grandmother though, and they would speak Ilocano and Tagalog at the same time. So I do speak a little bit, and I understand more than I speak. So a lot of times when the patient's talking to me in their dialect, I know what they're trying to tell me. A little bit harder to communicate to them, but we work through it. The hard thing is when I do try to speak though, I'll mix my Tagalog and Ilocano up and everybody will go, yes, doctor, because I know they're laughing at me, but I'm trying my best.
So
Hazel.
for me, I grew up Ilocano, and then I went to college at at UH, taking Tagalog class, and then I came back and started practicing, and then majority of our Filipino population here in Hawaii is Ilocano. And so my head was very confused with Ilocano, Tagalog, and English. But thankfully, a lot of our Filipino families, they understand English, but can't speak it as well. I understand Ilocano, Tagalog, but I can't say it back. So it's kind of this weird conversation where there's almost 3 languages happening at one time, but it works. But I decided to take a step further and started learning Ilocano 101, trying to be able to communicate better with our patients. So Dr. Vera and I are actually taking Ilocano 101 class at Maui Community College right now. Naimbag, malam. So, for the younger generation out there, if you're thinking of going into the health field and you want to practice in Hawaii, we cannot encourage you enough to really embrace the Filipino language now while you have free teachers around you, it's going to be amazing for you down the line. So please embrace your language.
And not just that, I think that it's important that if you have children and you come from another country and you speak a different language, please teach them, because it's going to just give them a leg up later on when they're older.
Yeah.
You know, one thing, I know we're talking about language and communicating with patients, but one thing I have found that's harder during this time with the COVID is patients who don't hear as well are having a hard time, because they can't always, you know, I'll see a video, I'm watching them and they're like this, you know, with their speakers because they can't hear me, or just, I'm not sure if I can do this, but this is the visit like this.
Yeah.
And I see the ear in the camera. And then unfortunately, when I do bring patients into the clinic that don't hear as well, they lip read. And with the mask that you have to wear now with the patients, I notice they can't lip read. And so I've trying to struggle through that a little bit, and whether that's with email or texting, but I know those folks in my practice have had a little bit difficulty understanding kind of what I'm saying, just because of, you know, and with the practices closed down, I can't get them to audiology to adjust hearing aids and that sort of thing. So that's just been another thing I've noticed because of COVID.
Great. So tell me, especially for you two, Dr. Lyla and Dr. Hazel, you guys are primary care providers, and can you tell me your experience in diagnosing COVID-19? What was that like?
Well, our first COVID patient, I think, came in March. We had been testing in the clinic because we were worried about anybody who walked in with an upper respiratory infection or a cough or a fever. So they'd wait outside. I don't mean literally in clinic, but we'd have a place outside where we would test them, and we'd mount up in full PPE, which is very hot. So we're talking about face shield. This is my face shield here. So we're talking face mask, face shield like this, big old gown, and you're seeing the patient outside in like 90-degree weather, 80-degree weather, and swabbing them outside. So that's been really difficult, and people are really anxious and scared. And at that time, it took maybe 5 days to get your test back, which is really hard for them because everybody's anxious about what to do. Are they positive? Are they negative? What should they do now? So we used to do that in clinic. Now, more so because the hospitals have opened up a lot of the drive-through testing. If anybody has any contact or if anybody has any symptoms, they go to the drive-through testing for that. So we've only tested a couple people that were actually here now versus March, where we were testing a lot more in clinic.
So for pediatrics, prior to COVID, a lot of our kids who come in with complaints of fever, cough, runny nose were just a typical common cold, right? Oh, it's just a cold, don't worry about it, give it a couple of days, your child will be fine, call us if this happens after a week. But now with COVID, it's totally changed the way pediatricians have to think about the simple cough, cold, runny nose, vomiting, diarrhea, because we worry that these kids are now carrying COVID and that they may transmit it to Lola, Lolo, Nana, Tata at home. So instead of like, it's fine, just watch it, now we're having this big discussion of whether or not, okay, is there any chance this could be COVID? We need to test this child. And so we didn't start seeing COVID in our practice until very recently, maybe the past month or so. There was hardly any COVID in the pediatric patients early on in March, probably because of the lockdown and schools closed. So kids weren't out and about getting it from anybody else. But this time around with this like recent surge in Hawaii and a lot of adults getting it, they've been bringing it home to their children. And so the cases that we've been seeing in our practice were pretty much it was from someone at home that gave it to them. I do have one child in our practice who is 3 years old, who was positive for COVID. Mom is a healthcare worker, but she tested multiple times negative for COVID. And she was never symptomatic, it was only her son. And so we never really figured out where her son, 3 years old, got COVID. So the whole thing with asymptomatic carriers is real in Hawaii. So please remember that. But for the most part, COVID for children our kids have been doing really well. Usually it's very mild fever, cough, runny nose, a little bit stomach, vomiting, diarrhea. After 3-4 days, they do fine. But really, when I talk to the parents, it's, oh, my child did fine. It's me. I'm the one with the shortness of breath. I'm the one who's fatigued. I'm the one that's dizzy. I'm the one, after 10 days, I'm still struggling.
And then you guys are ordering providers of these tests, right? So when we order the test, the results come back to us. What's it like when you make that phone call that you're going to tell the patient their test came back positive?
Hazel, did you have a lot of positive tests for your kids?
Well, I mean, the parents are so anxious. A lot of times it's the parents that were positive first, right? And then when they call us, it's, oh, my daughter now has fevers. Well, you know, pretty much majority of the time when there's a positive COVID at home, it's not a surprise to them when the child is positive also. It's those very few that I've had, like the mom where the child was 102, 103 fever and no positive contacts. So much anxiety, constantly calling, a lot of what ifs. They equate with all the stories that they're hearing about people dying out there, and they're worried about their child, that's happening to them. So it's a lot of reassurance on our part that majority of kids do fine. But when I do tell them that, you know, your child is COVID positive, I try to reassure them that the kids do fine. Watch out for vomiting, make sure they stay hydrated, control fevers, watch their breathing. Those are the big complications that we watch out for in the immediate few days of diagnosing COVID. And I stay in close contact with them. I check in on them once in a while. And then after their 10-day quarantine, I follow up with them to make sure that their child is back to normal.
How about you, Dr. Prater?
For adult medicine, I think of COVID as not just your own disease, but it's actually a family disease here in Hawaii because it affects so many members. There's different ways you would treat the child or look at the their child's prognosis versus the parents versus their kupuna or their nanantata. So you have to not just think about your patient, even if their parent or the child is not your patient, you have to think about how it affects the whole household and what you have to counsel the household to do. The first few times I had to tell someone they were COVID positive, they were very scared because they were seeing things from Italy and New York, and they were worried, you know, about mostly what if my mom gets it? You know, it's something very, very fearful. You don't want to be a child who brings COVID home to your mother or father and they end up dying. So it's been a lot of questions about that. People don't worry so much about themselves, but more so about others, which I found a lot in our community, and I'm sure y'all would agree. So it was scary at first. Now it's people are like, I have COVID, don't I? It's COVID, right? And sometimes, like when it's not COVID, when it says negative, right? They're like, oh, thank God, now I can go out. But then I have to counsel because I cannot stress enough that a negative COVID test is not a negative COVID test. A positive COVID test is a very good test, like it says, you're positive. But a negative COVID test could still be COVID. It's wrong at least 20 to 40% of the time. So you have to let them know that just because you're negative, that means you don't go out of isolation. You have to finish those days of isolation. And your isolation is different if you're negative versus positive. So if you're negative, your isolation lasts a little longer, 14 days versus 10 days if you're positive. Because we have to wait to see if you develop symptoms at some point if you had a positive exposure. Because there's a reason you're testing.
I have a question from the audience. I live in a household with lots of people. What am I supposed to do if I test positive? And how do I get one of those hotels to quarantine? What do I do?
You know, the health department is supposed to direct that. Getting back to the last question, just real quick, the guy I told last night that he had COVID was really shocked because he had the sniffles and what we call low-grade fever. He wasn't even that sick, but he does go to dialysis and he's with other people that are vulnerable. So we basically didn't let him go into dialysis. We kind of blocked him at the door as we screened, and then we sent him for a test and it was positive. But he's like, I can't even believe I'm positive. I'm barely sick. So that's one reaction, like the others alluded to. And then another reaction I get that is kind of curious, and a few of the other positives I've had, they said, yeah, I knew I was positive. So why don't you know? They said, well, because my wife has it. So they had it in the family already. And then to them, it's like, well, of course I have it. My wife has it, or my son has it. So that gets back to this question. There is a program in place, or has been in place, or getting expanded, where they will try to get a COVID positive family member out of a large household. So, and put them in a hotel designated by the health department. Now, I think we're all aware of some of the struggles the health departments had because of this kind of explosive increase in cases over the last, 2 to 4 weeks. But that program is in place, and in a perfectly working system, the positive would be transmitted to the health department, and one of those contact tracers would be in touch with the person within 24 hours or sooner, and figure out kind of what's going on in the household and if they need to move them or not. And I hope that's what we're moving to, because that's how, especially if 5, 6, 10 people live in the household, that's how you keep everybody else from getting sick. Because all those other people presumably work or go to school or interact with other people. Granted, a lot of stuff is being shut down right now, but that's how you keep it, number one, from spreading in the household, and then from spreading outside the household. Because those people with direct contact with the positive need to be quarantined as well in the house.
So what do you tell immediately as a PCP to your patients, like right in your office? What do you tell them?
When they're positive, or?
Yep.
Okay. So
you just tell them they're positive. Like, I got your test results, you're positive. What's your counseling?
In answering the question that the viewer was asking, if they're positive, they need to isolate. So it's not just about quarantining at home, it's about isolating yourself from everybody else in that house. I don't know how you're going to get a hotel. I'm not sure, that program kind of just rolled out. Hopefully you can find one, but if you can't, it's important that you have to have your own space, your own bathroom, hopefully, if you have that. And a lot of people don't have their own bathroom that they can use that other people are not privy to. Because COVID can spread, it's a big place for spread in the bathroom. Like public restrooms, huge place, because people don't understand that COVID aerosolizes, which means goes into small particles into the air every time someone flushes. So you walk in, you don't want to go into a restroom right after somebody that you don't know, because it might be up right there up in the air. So if you need to have your own bathroom at home, you need to have your own space. You don't share not napkins, but utensils and plates and glasses. Go to paper plates and things like that. And we mean no contact, because the people in your household need to quarantine 14 days from their last contact with you. And if they are in contact with you again, another 14 days starts from the last contact. So that's really important. If you have to see your family members and you don't have a separate bathroom, like say you're a parent and there's kids and there's no way that you cannot help your kids, or you're the caretaker of your mom and dad or something, and you can't everybody masks up. What's up?
Oh, no, you cut off a little bit, that's all.
Oh,
go
sorry.
slow. You get excited and you cut off, so slow down.
Excited. No.
Okay.
But, everybody, like say you're the one taking care of everybody else and there's no way to get help. You have to mask up, they have to mask up. If there's no way to avoid it, you have to wear your masks in the house, 100%. So if a parent has COVID and they're taking care of the kids and you don't know if the kid has COVID, they're asymptomatic, you want to make sure that you're not the one passing it to them just in case, although they might be the one who passed it to you. You wear your masks in the house, and you don't share utensils, you don't kiss, you don't hug. It's hard. It's there's no other word. It's hard. I mean, family is family. It's really difficult not to be there for them.
Yeah.
I'm gonna add one more thing to what Dr. Prather and Dr. Allen was saying. So if you have a positive family member at home, like what Dr. Prather was saying, everyone at home needs to quarantine, meaning everyone needs to stay home for 14 days and not go out. So the current recommendation is that if you have a positive COVID at home, you should also get tested, everyone at home, and wait until the result comes back.
Repeat that one more time. Repeat it one more time. Say it loud.
If you get tested, stay home Please stay home. Do not go to work while waiting for your test. But even if it's negative, if you have a COVID positive family member, your COVID test can be negative, but turn positive later. It can take up to 14 days for your COVID to turn positive. So please, 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 if anyone in your family is COVID positive, everyone at home needs to stay home. I know we all need to go to work. So a lot of people say, I'm fine. I don't have any symptoms. I'll just wear my mask. I'll social distance. But for mitigating this COVID, to get COVID out of Hawaii, we all need to make a little bit big sacrifices. And please remember the guidelines that if anyone's COVID positive at home, get tested. Even if you're negative, stay home until 14 days.
This question is for Dr. Ireland. You alluded to one of the dialysis patients getting testing positive. Can you talk to us about, are dialysis centers safe? And if they are COVID positive, what happens?
They are safe. And nationally, what they've determined through some studies and just getting information from a lot of dialysis units, particularly in New York City, where there was a lot of COVID a few months back, is that most of the dialysis patients they're finding contract COVID, that get COVID, get it outside the dialysis unit. One place in particular is how they're getting to and from dialysis. If they're using some kind of public or group transportation, that was one thing they found. But we have in Hawaii found patients that are on dialysis with COVID. And there's two main companies on Hawaii that do dialysis, Fresenius Liberty and US Renal. And both of those companies set up special units to do dialysis for COVID patients. So for instance, the one at Fresenius is on the campus of Queens West. It's an old unit that had been closed. It wasn't even used anymore. And 3 days a week, they use it for COVID patients that are COVID positive. And 3 days a week, they use it for patients what are called PUI, patients under investigation that have had a COVID test because they had a fever or something, but that test is still pending. So they have segregated out the dialysis patients that are PUI or with illness from the rest of the dialysis population. So that's how they're separating them so they still get their treatment. The other thing is they're arranging private transportation from their house directly to dialysis and back. And that can be with a van or an ambulance even, and it's someone in full PPE. So you don't have to go on public transportation or even with your family members or drive yourself when you're positive from COVID to go to dialysis. Now in the rest of the dialysis units, the regular ones where they're, the regular folks are just going for their regular treatments, they've set up stations at the door, much like we see at the hospitals and the Capitol and things, where someone meets you at the door and says, do you have symptoms of shortness of breath, fever, cough? They take your temperature and then they admit you to the dialysis unit if all those are negative. People in dialysis, the nurses and the workers are in PPE, and then they ask the dialysis patients to wear masks while they're in the dialysis unit. So there's a lot of precautions taking place. They're working. I knock on wood, since this began, have been rounding in the dialysis units. I've been rounding in the hospitals. I wear my mask everywhere I go outside the hospital and in clinic for the last 3 or 4 months. And, fortunately, I continue to swab COVID negative, even though, like the other doctors here, we've actually been in the same room with COVID patients. But if you take the precautions the government's recommending, they work. And they work for people who aren't in healthcare too. And that's why, and we may talk about this later, you just can't stress enough how important it is, at least right now when there's a lot of COVID in Hawaii, to wear a mask when you're outside your nuclear family, and wear a mask when you go out, wash hands, etc. And while I'm just a little tangent here, but while I'm thinking about it, other people in my practice, and unfortunately a family member of mine who got COVID, have been visited by extended family. And so, for instance, people you're with every day, you're with them every day, you don't wear a mask, that's as safe as it can be. But when extended family comes over, an auntie or a cousin comes into your household and they also drop their guard down, don't wear a mask in your house, that's actually putting the whole household at risk. And I've seen cases in my own practice and unfortunately my extended family on the North Shore where someone did get infected, possibly through those type of visits. So when you're not with your nuclear family, keep your guard up, wear your mask, and wash your hands.
Thank you for that. We mentioned about inpatient care. Again, at last Facebook Live, we had our doctors talk about how we take care of the COVID patients in the hospital. After they are well enough and recover in the hospital, we let them back home. And as you guys as primary care providers, you guys receive them, right? So can you talk about a little bit about that? What happens after they leave the hospital and goes home? Dr. Prather?
So a lot of times, my job as their primary care provider is to see if they're sick enough to even go to the hospital. So even before they go to the hospital, we're monitoring. You have to check shortness of breath. Are you short of breath? Can you breathe? Can you talk complete sentences? Not everybody has an O2 sat monitor, but if you can't talk 3 or 4 words without taking a breath and you sound like this and I can't breathe, you need to call me. You need to call your primary care physician and you need to get assessed to see if you need to be in the hospital. When they're in the hospital, they usually get assessed to see if they need supportive care, which could be oxygen by nasal cannula, which is the problems in the nose where a higher level of oxygen is delivered to you than room air. If they need BiPAP, which is a machine that actually blows oxygen into your lungs. And do you need ventilatory treatment? So do you need to get intubated, go to the ICU? Once you're released from the hospital, a lot of COVID patients, even the ones who just needed simple oxygen, will still have a hard time breathing when they're doing things. Even the patients at home that didn't have to go to the hospital complain of significant shortness of breath for days, weeks. We haven't been to a month yet, but I'm predicting probably months after, they're going to have some issues, maybe decreased endurance, maybe decreased ability to do things that they wanted to do because their lung capacity has been affected. So you have to really watch that. So I try to get them, if they're having problems there, with a pulmonologist so that someone else is watching, a specialist for the lungs is watching them to see if they decompensate or if they need other medications that could help them breathe better. I try to get them, if they have a renal failure, so kidney failure, to somebody like Jim, to just watch them to make sure that the kidneys recover from COVID. And then just a matter of touching base with me at least 2 weeks after they're out of the hospital, and then 4 weeks after that. It's a process. So we're just at that part. I predict probably we're going to be seeing these patients more often just to make sure they get back to normal.
I had a question from earlier about, I didn't really understand it, but it makes more sense now. Somebody asked about telemonitoring for symptoms. I believe that means like checking O2 sat and those type of things. How would you recommend that, or do you recommend something like that?
I do, but if someone can't get an O2 sat, which is this. So this is a home O2 sat monitor.
All right,
so,
props.
Yeah, you like that? So you wear it, you turn it on like that, you press the button, it turns on, and then you put it on your finger, and then it reads your O2 saturation. Is it upside down? That's my O2 sat.
Okay.
Hello.
I can't see.
Anyway.
What's the number? Let's see.
Let's see. What am I? I can't see.
You are
95, right?
But your heart rate is 108. You're nervous.
You're a little tachycardic.
A little bit nervous.
A little bit nervous. But this is an O2 monitor. So in general, I think HPH or Schwab has a policy that if your O2 sat is under 93, so you're monitoring with this, then you go into the hospital. You go into the ER and you get assessed, because normal O2 sat runs about 96 to 99. If you're running 93 and you don't have like COPD, which is like emphysema, you don't have chronic lung problems, and you're just a normal everyday person, that's a significant difference. So you need to get assessed. Call your primary care physician and see if you need to go in. Go ahead, Jim.
Yeah, this gave me just a little revelation sitting here. I know that some healthcare providers are providing O2 sat monitors in lieu of hospitalization. So my relative on the North Shore who got COVID infection he's a Kaiser member, but did get a O2 sat from Kaiser because they didn't want to put him in the hospital and they tried to keep him out. But he called in once or twice a day with the number, and once it got too low, they sent an ambulance and they picked him up. But I'm wondering now, you know, those aren't super sophisticated medical devices, and they're, I think, on Amazon under $50. So in my opinion, maybe that's something that we as physicians could suggest to the health department that they provide to the COVID patients. You know, when a positive result comes in, if they're not in the hospital and the contact tracer calls them, maybe we could see if the government could provide one to people, and then the contact tracers or whoever's monitoring these people, they monitor the O2 sat with a trigger, like Dr. Prather said, at under 93, that we escalate it up their care to their PCP or to a hospital. But that might be a way that we can use technology to, because we know the hospitals are very crowded now. You know, all the major hospitals on Oahu have at least 20% of their beds now are COVID patients. So we all know everybody's busy, but that's a way to keep people out of the hospital, but still make sure that they're staying safe. So that gave me a good idea, and I'm gonna text that idea to somebody once this is over.
Yeah, say it's through PMAH said so. I think it's a good idea because, you know, if you're a diabetic, you have a glucometer, you check your sugar, right? And most people, or a lot of people with blood pressure issues, they already have their blood pressure cuff at home, or they go to like Longs and get their blood pressure checked, right? Or go to the fire station. I mean, why not for a little device that checks your oxygen if oxygen's a problem? Makes sense, right? Stuff people could do at home. So totally makes sense. We'll see how it comes out from this. Dr. Abinsay, anything to add about outpatient care from inpatient?
So, I mean, in pediatrics, we've been very lucky that a lot of our kids with COVID end up not needing hospitalization. So we haven't had much guidelines in terms of follow-up for inpatient pediatrics with COVID, but I did want to share that pediatricians are always on the lookout for this syndrome, and some of you might have heard about it already, called multi-inflammatory syndrome of children, MISC. So 2 to 4 weeks after a child has COVID, they don't have to be hospitalized. They could have just had like very simple cough, runny nose, fever, a little bit vomiting, diarrhea, got COVID, mom and dad had COVID, recovered after a couple of days. But if 2 to 4 weeks later after, they call me and start telling me that they're now vomiting more abdominal pain, their eyes are turning red, weird rash, fever, shortness of breath, I'm freaked out, because now there's this entity called MISC, which is a new diagnosis that just came about after COVID, that these kids can get pretty sick pretty quickly. And so if you have any child out there that was recently diagnosed with COVID and they're now experiencing any of these new symptoms, please call their pediatrician right away and let them know what's happening, because these children can get sick really fast and require hospitalization.
We
People
talked
are
about
probably wondering about where to get an O2 sat monitor.
Jim said Amazon.
Yeah, you can get one on Amazon, but I actually like sent my patient to Longs, not thinking they'd actually have one, but she got one, Longs. And so you might want to check your local Walmart or Walgreens or Longs and see if they have one. I think it was about $20, you know, and she's severely asthmatic. So I know she's really on that edge, and I need to know what her O2 sat is. But she was able to get one right there. I would have to stress though, if you don't have significant problems right now, someone else might need it. So the monitors in bulk and like hoarding them, please. Someone might need it more than you.
And so we're talking about, sorry. Let me talking about, you know, care of COVID patients as outpatient. We talked about, you know, the hospitalized ones where you have to like wean their oxygen. Are there any other treatments or medications you give the patients who are symptomatic with COVID? And what do you tell patients, or any treatments you recommend for patients with COVID that are asymptomatic? Controversial questions. Who wants to answer the question?
I'll just do the easy one, the peds ones. The peds ones, what these guys think. So in pediatrics, whenever we have a child diagnosed with COVID, like I said, it's very It's just symptomatic care. It's treating the fevers, it's treating the vomiting, the diarrhea. So it's just fever control with Tylenol, ibuprofen. It's making sure that they're not getting dehydrated, giving vomiting medicine if they need it. If they're asthmatic and COVID on top of it, their asthma can get exacerbated or worse. So we just give them their typical asthma medications. And surprisingly, in Hawaii, out of all the kids that have been diagnosed with COVID, 40% are asymptomatic, meaning 40% of the kids diagnosed with COVID had no symptoms. So in those cases, they were probably checked because someone at the family had COVID, so they had to be screened. And in those cases, we don't treat them with anything. We just tell them you need to stay home for 10 days. So if you're an asymptomatic carrier, no symptoms, and you test positive for COVID, the guideline is that you stay home, quarantine, isolate for 10 days from when you tested. Leave it to the adults now. Harder question.
What was the question?
How do you treat your outpatient symptomatic patients, a patient with symptoms, and the ones who are COVID positive without symptoms? What do you tell them? What do you give them?
It depends on the symptoms, but in general, it's supportive care. So rest, push fluids, monitor your symptoms, cough medicine, fever reducers like Tylenol, ibuprofen, naproxen. You treat what's happening, what's going on. I don't really use prophylaxis. There's not really a proven prophylaxis. I know a lot of people will talk about hydroxyc chloroquine, but all the studies that are out there have disproven hydroxyc chloroquine as an adequate prophylaxis or successful prophylaxis in individuals with COVID. So it's treat the symptoms until you have symptoms you can't treat at home, and then you go to the hospital.
What do you tell patients who really want a prescription for hydroxyc chloroquine, or really want to take this herb pill from the Philippines that Bongbong Marcos is taking to prevent COVID? What do you counsel them? What do you tell them?
Well, with hydroxychloroquine, I mean, all drugs, they have side effects. And it's funny to me how people who like are so afraid of medicine, like they don't want to take any medicine, all of a sudden want this medicine that could potentially stop your heart. So there are certain conditions people who shouldn't be on hydroxychloroquine, like they can cause severe heart block and your heart to go into fatal arrhythmia, which means you can die from hydroxychloroquine. So it's not a benign drug, you just don't want to take it. So usually the answer is no to something like that. If it's something that's benign, like it doesn't have any other side effects, then and it makes you feel better. I mean, there is a 30% placebo effect, which means when you're taking something, you feel like you're doing something about it, you feel better. And that does help somebody feel better and maybe even get better. So if it's not going to hurt you, great. But don't just take something because you see it on the news. Talk to your doctor about it.
I have a question from one of my audience. Okay, go ahead.
Oh, when we first heard of hydroxychloroquine as a possible remedy for COVID, and you know, we use it a lot in patients with kidney disease from lupus, from SLE, which is an autoimmune disorder that can hurt the kidney, and it's actually indicated for that. And so I have, you know, I don't know, 20 or 30 patients who are on hydroxychloroquine. But when it first came out that there was maybe a buzz about it, I tried to order some in case we wanted to give it to patients with COVID. And I couldn't even get it. I mean, I tried to order it from the normal places to order pharmaceuticals and I couldn't even get it. And then as we waited, then the data suggested that maybe it didn't help. And then I just canceled the order. But I agree with Dr. Prather that, you know, you can't just jump on something that's a fad or it's mentioned when it could have, you know, dangerous side effects. You know, I'm maybe on the extreme of as far as the other PCPs on my approach to COVID patients, because a lot of times I'm not with the patient when I get the positive result. So unless the patient feels completely normal, it's been my practice, and I've had maybe a total of 10 or 15 patients personally with COVID. I send them to the emergency room. And the reason I do that is I want to, because I'm usually not with them. So I'd like them to get their pulse oxygenation measured. I'd like them to get a chest x-ray, because in some patients that deteriorated, the ER sent them home, and then a week later when the patients came back, the chest x-ray was a lot worse. So I like them to get that, and as well as some basic lab tests. And I would say of maybe half the patients I've sent to the ER, they are kept in the hospital. The other half were able to get discharged with close follow-up. So in the outpatient setting, I generally don't start any medications, but if they're sick enough to be hospitalized, they do have, and this might have been covered last week, plasma, convalescent plasma, dexamethasone, and some other medications that are starting to show that they are effective. I think that's why, although we're still unfortunately seeing fatalities, it's way lower than it was when this first started in March and April. And the patients in the ICU, although there are still patients in the ICU, that's way lower than before. So, I mean, there is a little bit of bad news right now in Hawaii that we're in this bump surge, if you will. But the good news is although people are passing away, it's not like it would have been in March if we had the bump then, and the ICUs aren't as full as they would have been because of these therapies. So that's the good news. And that's, I think, the best news until we get a vaccine.
Hazel, you wanted to add something earlier?
I did, but now I don't remember.
Okay. The question from the audience, going back to everything we talked about, out of curiosity, what type of PPEs do you wear in your clinics, in your outpatient clinics?
So for me, it's gloves and N95 mask. It's been very difficult for the primary outpatient doctors to get full PPE, including the gowns. So I wear scrubs at work, and then as soon as I get home, scrubs go straight into the washing machine because I don't want any germs on my scrubs to get to any one part of my house. So for me, it's just face mask, shield, glasses, and N95.
How about you, Dr. Prather?
Same. So what was the part about like which one would I choose for myself? Is that what you said?
No, what do you wear for your PPE in your clinic?
For myself. Okay, so
Yeah.
This is my 95. So this is actually my KN95 because I have not been able to find the the N95 that is fit tested for me. So fit test is really important when you're wearing a PPE because if it doesn't fit right, it leaks. So this is one of the KN95s that the Philippine Medical Association got for our local providers, our community providers, especially when it was really hard to find any kind of good mask and people were like hoarding them and selling them and jacking up the prices. So they've been able to give this to us as community docs for just their cost. So not jacking up the prices at all. And this is one of them. And you wear it like this. So it fits really good. Fits really good around your mask, your face. So no leaks. You can test that with your glasses. I don't have my glasses with me right now, but I do have my goggles. So these are my goggles. And if I'm wearing my glasses here, right? So my glasses, then I wear my goggles because they cover my glasses because then I can't read, right? So it's me seeing a patient, and then the mask on top of that. Okay. Then I got a gown, big old gown that's super hot when I have to go test somebody, and then gloves, of course. But I don't have these goggles. Then I got my face shield, of course. So got a face shield. I love this because then I can. So that is my PPE regimen for the outpatient clinic, and it's even worse if you're inpatient. But
yeah, so a lot of people think that's kind of excess, but really that's the protection that us healthcare providers are working with. That's how I look like every day with more gowns and hot things on. So thank you for that. Do you think with the patients with language barriers, how good is it for family members to be interpreters, especially for sensitive conversations? What is your feelings about that?
I personally feel if it's a very sensitive subject, are you giving bad news, a new diagnosis? I think it's very important to have a third person who is not a family member, such as a staff member or an official interpreter, to be there to interpret your words, your own words, word for word. Sometimes when I have a family member helping me translate to their grandma or their grandpa, I understand still what they're saying, and the translation gets altered based on what they do or don't want their family member to hear. And they sometimes just, or they don't know the words, or it's difficult conversation for them. So I feel like for sensitive subjects, it is important to have an outside person, not a family member, be your interpreter, if there is that option.
In my clinic, so I'm a surgeon, so I deal with cancer patients all the time. Sometimes I'm the one who helps them understand their diagnosis. And again, I push everyone to at least understand the different language. With me, I don't speak Ilocano and I speak broken Tagalog, but I understand for the most part what they're saying. And I work for a hospital system, so if I need an official interpreter, then one will be provided for me. And for me who's consenting or getting permission for a procedure, it's a legal thing. So I have a real interpreter interpreting everything I say for the legal aspect. But if it's for bad news or who's going to take care of them or trying to help to make the decision, I think I welcome family members to come. I want them to come, especially when it becomes a life or death kind of surgery, a cancer surgery. Because at the end of the day, people in Hawaii work in family groups and everybody's going to take care of everybody. So I'd like to have one conversation with everybody on one visit. And everybody can ask me their questions and somebody can interpret the way. And I also ask the patient or the family tells me, oh, I don't want the patients to know this, but I am saying, I always say that patient is my patient. You are not my patient. Because at the end of the day, we have responsibility to the patient first. And it's a clinical judgment how we want to approach that. Right? Anybody else? Good. Okay, Dr. Ireland, since you're on the state task force, where is Hawaii with COVID right now?
Well, speaking as a community physician, I've been invited to some meetings and especially with my previous government work and been on some different committees and tried to, volunteer my time to assist in just kind of what everybody's trying to do around the state to get this under control and also, ultimately open up the economy in a safe way where, people can come here and as tourists and people can get their jobs back. I think as everybody knows, we saw an explosion of cases really in the last 2 or 3 weeks. And I know this is an outpatient forum, but just going to inpatient, about a month ago, most of the hospitals on Oahu had from 1 to 5 patients with COVID in the hospital. I think one bigger hospital on Oahu had maybe 11 patients. And maybe in total, it was 20 patients in the hospital on Oahu a month ago. And I think in a lot of doctors I knew and ER people and EMS people would say, yeah, we'd see someone we thought had COVID once a week, maybe once a day at the most in the busier ERs. And then all of a sudden, about 4 weeks ago, it changed. And then it's just been escalating where one of the hospitals one hospital on Oahu had 115 COVID patients in the hospital. Some of the smaller hospitals on Oahu had 25 to 30 patients in the hospital with COVID, and their entire inpatient census might have only been 80 to 90. So they had up to a third of their inpatient beds covered with, taken with COVID patients. So, I think it was very alarming, and I'm sure that the primary care outpatient docs saw this as well in their own practices, where all of a sudden there's just COVID patients everywhere. And it was a little frightening. And when we saw that at least 2 weeks ago, when we saw the hospitals ramp up, that's when I think what precipitated these recent stay-at-home orders on Oahu. And simultaneously, unfortunately, the Big Island has seen a spike. There's a care home on the Big Island where maybe something like more than half the residents of that care home are infected with COVID. There's been some deaths we've seen on TV. And so the Big Island is having a smaller spike in parallel. Maui and Kauai, not as much, especially Kauai. So unfortunately, we're in this place where we really didn't want to be. I think I personally, back in, April, May, was feeling really good. Like, wow, this lockdown worked. There's hardly COVID here. We can cruise it. And although I still wore my mask, I felt really good, like we beat this thing. And I bet you a lot of other people felt that way too. And I was driving from the North Shore to around the windward side of Oahu on July 3rd. And I just saw all the beach parks packed. Huge tents, big families, close friends, fresh fish, just having a great time. And that was the windward side. And I'm hearing it's happened everywhere. And I have a feeling, this is just my own guess, is that all the folks on Oahu, not all, but me, a lot of other people were feeling so good, we really let our guard down. And we let it down so much that we really spread this thing big time in July. 2 to 3 weeks later, end of July, we start seeing these numbers pop up. And by the end of August, we're in this pretty, I wouldn't say dire situation, but really bad place to be, where it looks like now schools can't open the economy, had to shut down again. And so personally, I just think, I think we'll all learn a lesson from this and how to kind of go about it. Like, again, now once this little surge starts falling down. And the good news is I track the hospital numbers every day. And over about the last 5 days, the hospital numbers have decreased. Not a lot, but they have decreased. So at least they haven't surged or gone up. So I think we're now kind of in this plateau, and we're going to start dropping down again with the measures that are in place. But until we get a vaccine, we're always all going to just have to have our guard up. And that's just kind of the way it is. Now, one other thing I want to say, unless you lived through the 1918 Spanish flu pandemic, which probably 99% of people didn't, this is brand new for the United States and the world. We had SARS 20 years ago a little bit, but they contained it. We had Ebola, they contained it. H1N1 was worldwide, but it wasn't as deadly as COVID-19. So I know there's a lot of criticism all over the place across the country. Some of it's deserved, some of it's not. But what I will say is we meaning everyone in the government and healthcare providers, we had to make this up as we went. I mean, there was sort of a playbook for what to do, but not really. I mean, when the president cut off flights from China, that was unprecedented, where we wouldn't take flights from another country. But unfortunately, by that time, it was too late, because people had already left China and gone to Europe and Seattle and everywhere else. So just to not quite so critical, we are learning as we go. And if we ever unfortunately have to go through this again, and I hope we don't, I know we'll do it better the next time.
Right.
So that's a long-winded answer to your question. But the short answer is things are plateauing in the hospitals. From what I hear, EMS is not going on as many COVID-19 calls on Oahu as they were a week ago. So things, I think, in my opinion, are working. But we got to hang on and do the tough love a little longer. I'm really, and I don't know if we're going to talk about this today, but I'm really hopeful for a vaccine sooner than later.
So that dovetails into a couple questions. The economy is not the best and people are losing their jobs. Can you guys comment on access to care now that, many people are losing their jobs and losing their health insurance? Do they get to see you anymore? What should they do?
Well, for some patients, can you hear me?
Yep.
Can you hear me okay? For some patients, if they qualify for a Quest, they can go and apply for that, which is a state Medicaid insurance. You have to meet certain financial guidelines in order to get Quest. But if you do qualify for those guidelines, go to the Quest office and apply. Or if you're anticipating losing your job or you're losing your insurance, try and get that information beforehand so you're ready if that does happen to you. For those that make money that doesn't that would disqualify them for Quest, there's clinics like Bayanihan Clinic Without Walls, which has a program now that if you've lost your job and lost your insurance, you can still be seen by a doctor. There's also the program from the Lieutenant Governor, which Jim has helped spearhead as well here in Kalihi. Jim, what is that clinic called?
It's the Aloha Free Clinic, and it was originally at the end of August, but that will run till the end of December. It's in the building with Dr. Pang's eye clinic at the corner of North King and Gulick.
So there are those two options for care if you lose your insurance. So hopefully people can still get to see their doctors and get their medicines. If people need their medicines, I've been telling my patients that are going to lose their insurance. There's some really good drug plans out there at Walmart, at Walgreens. I'm not sure at Long's, but definitely Walmart and Walgreens has cash medications for the most common blood pressure medicines, some of the diabetes medicines, some other medicines for other chronic conditions, where you can get them for very little copay. And if you have a good relationship with your doctor, they'll be able to fill your prescriptions and you can still get those medications. So what I've been doing outpatient, if I know my patient is going to be losing their insurance soon, if they're not on one of the medications on that plan, I try to switch them over so that they can get their medication for at least 6 months in case they don't have insurance for that time.
So can I just piggyback on the Bayanihan Clinic Without Walls is an affiliate of Philippine Medical Association of Hawaii. So in order to enroll and get plugged in for those interested with our free job loss program for medical care, they can visit PMAH-hawaii.org. And then when you get onto the homepage, there'll be a very big icon right there to enroll now. And then for Aloha Clinic, because we've had to refer some parents there who've lost their jobs in medical insurance. For what we did was just Googled Aloha Clinic, and then there was a phone number right there, and you just call the clinic.
Yeah, the Aloha Free Clinic at King and Gulick, we actually provide generic medications for free, as well as labs for free. And just while we're on the brief topic, the Pierre and Pam Omidyar and the Hawaii Community Foundation have been very generous in supporting that clinic. So we are able to keep it open till the end of the year. When we first opened it, we thought 3 months would be enough. The economy would be reopened, but unfortunately that's not the case. And one of the things I worry about, and I think a lot of healthcare professionals worry about, is it would be a shame if we got through this COVID with so few people passing away, yet 10 times that many pass away because they couldn't get their blood pressure medicine, or get their diabetes medicine, they had a stroke or something. So we really want people to connect with their PCP. Probably if you have a long-term relationship with your PCP, they'll give you a cash discount or maybe even for free for a short period of time. And if not, the community health centers or the Clinic Without Walls, the Aloha Free Clinic, because we're a big family on this island. We're all here together and we're in this together. We don't want anybody to go without healthcare. My gosh, especially a child. And we don't want anybody to go without healthcare because of this economic situation. And I think 2021 is going to be a new year, and I think things are going to be open by then. But I am, not seeing a lot of reopening in the next month or so anyway until we get this behind us. But we really want people to take care of themselves. I think Dr. Prather had a great suggestion as far as Walmart and their cash programs for long-term generic meds, very inexpensive. So there is stuff for folks. If they can just reach out.
Question from the audience. Should I get my flu shot this year? Is that gonna hurt or help my chances of getting COVID or making me sicker? I don't know the answer. I don't give flu shots. So Dr. Prather.
You want to say, Hazel?
I am preaching this to all my parents and to all my families every day since we got our flu shots in the clinic. Please, 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 yes, yes, yes. Everyone should get their flu shot every year, but especially this year. So the question about is getting the flu shot going to, what was the question, Morel?
Will it make me sicker or is it gonna affect my chances of getting COVID?
So getting the flu shot is not gonna affect your chances of getting COVID. The flu shot and COVID are completely separate issues, okay? So you're gonna get I strongly encourage you to get the flu shot to protect yourself. Because if you get the flu and on top of that, you can get, there have been patients who've been diagnosed with both the flu and COVID on top of each other. And one already is hard enough to try to recover from. Having two on top of it it's just, you're just making your recovery harder for yourself. So please, please, please get the flu shot. I counsel my patients that when you do get the flu shot, some small amount of patients do have a few days of feeling small fevers, a little bit of cough, a little bit of body aches, but that's not the actual flu. So this myth that the flu shot gives me the flu is not true, because it's not the actual flu. It's your body reacting to the vaccine and building up immunity. So the flu vaccine is not going to give you the flu. The flu vaccine is not going to give you COVID. The flu vaccine does not increase your chances of getting COVID. What does increase your chances of getting COVID is not practicing social distancing, not masking, not washing your hands, gathering when you don't have to from with people that are not from your home, and being near sick people.
Okay. Since we're speaking about, yep, great. Vaccines, controversial. Everyone's asking on this web chat here. When are we going to get a vaccine? Should I take the vaccine? What are your feelings about this vaccine? Go. COVID-19 vaccine, to be clear.
You know, there are vaccines out now, and I think people can Google and learn about this if they want, but without getting into a lot of detail, and I don't fully understand it myself, but vaccines go through a process. There's are they safe in humans to use? Do they work? How well do they work? And so it's a stepwise process. And usually this takes years, but because this is a national and international emergency, they've really shortened up the time frame. Now, a lot of research was done for SARS, the original bad coronavirus from almost 20 years ago, 17 years ago. So a lot of that research and the development of a SARS vaccine, they could use for the new SARS, the new COVID-19. And the genetic material of the new COVID-19 was published, I think, from somebody very early in the year and shared with the world so this vaccine development could be accelerated. So there's many, many vaccines out there that are being tested. There's kind of 2 or 3, I think, that are, quote, in the lead. They're in phase 3 trials, I believe, in the United States, where they've gone beyond the is it safe to now does it work? Because number one, you don't want to hurt somebody with a vaccine. And then number 2 is you want to get the dose right. So they're trying high, medium, and low doses. And then they want to know, does it work? And the way they find out, does it work, is 30,000 people get the vaccine, 30,000 people get a saltwater shot or a sugar shot, placebo, and then they follow those 60,000 people. And what you hope to see is people who had the vaccine, that group, gets way less COVID infections than the people who got the sugar shot. And then when all that data is available, you can then proclaim the vaccine working, and then you offer it to the public. Now, what's going to complicate this a little bit is this is such a national emergency that they're going to rush all this. They're going to tighten up the safety time. They're going to, and they're still monitoring, even the does it work phase, they're still monitoring for safety, adverse reactions. And the does it work is going to be shortened. So, you know, my guess is they're going to release this before they have all the data they would like to. However, they will not release it unless they feel reasonably it's safe, generates antibodies, generates protection. So, you know, they're saying November 1st. A lot of scientists think that's wishful thinking, but we'll see. I think personally, at least by January, it'll be released. But what people can expect is it'll be released in tiers, meaning levels, meaning probably first responders and healthcare workers may get it first, then people in nursing homes, then people with comorbid or other conditions like diabetes, hypertension, and then they'll kind of make groups of, because, you know, if millions and millions of people want it at once, but they don't have enough, they'll stratify who gets it. And part of the good news about that, if you're a healthy adult, is 1 million people get it before you. And then some of that safety and, you know, efficiency stuff and efficacy will get worked out. But the other thing they haven't worked out yet is, will you need a booster? And remember when hepatitis A broke here, I don't know how many years ago that was, a lot of people weren't immunized for hepatitis A, including me. I had to go get a vaccine, and after a period of time, I had to get a booster. The other thing we don't know yet is, like flu, the strains change every year, and we have to get a new flu shot every year. We don't know yet if this COVID changes. It hasn't been around long enough. I think it changes a little bit, but does it change enough where we need a new COVID vaccine every year? And that's just speculation. Who knows? But what I'm hearing now is we're going to need one vaccine and probably a booster at some point later. Hopefully that is available before the end of the year.
Okay, great. Anybody want to add about vaccines real quick? No? Okay. I want to take a COVID brain break because my head is tired. My head is tired. I want to kind of talk about juicy stuff for like maybe 10 minutes or so, just for fun, because it's my show. I want to ask each one of you, why did you become a doctor? What was your journey? We can start with Dr. Ireland. You had a weird journey.
Well, first of all, before I even answer that, my friend Queen, a nurse at Fresenius Dialysis, is texting me about critiquing my answers, mostly positive. So how's it, Queenie? But Queenie, runs our COVID dialysis unit. She's managing it. And so she's in a high-risk area doing a great job. And so how's it, Queenie? Thanks for your critiques on Facebook Live. The question.
Not you, I'm talking about you.
Yes, all right. So, So I wanted to be a vet when I was younger, a veterinarian, take care of animals. I loved animals, but I kind of evolved into this thing where I was going to go into the police department. I think that was my thing. And a lot of people don't know this, for a brief period of my life, I was in the Honolulu Police Department. But I was really leaning towards the police. And at 18, decided I needed some structure in my life, and I went into the military. I was in the 442nd 100th Battalion, which is a reserve unit. And they were the ones very well known for their work in World War II. With the Japanese Americans in Senator Inouye. That was my reserve unit. We were based at Fort DeRussy, which was great duty. They later moved to Fort Shafter. But when I enlisted in the Army, apparently you have to pick a specialty, something to get trained in. And I told them I want to be a military policeman. And they said, well, there's no openings for that right now. So, but there are openings for combat medic. How about that? And I said, well, sure, why not? That sounds interesting. And I'd like to be, help people. And so I was trained in the Army at Fort Sam Houston as a combat medic. And when I left there, that left me with training that was similar to an EMT or paramedic who works on the ambulance. And I was in the reserve. So at that time I was at UH, and I was undergraduate and working towards molecular biology and genetics was my interest. And I thought I wanted to get a PhD in that. But I was working in the lab at UH and also on the ambulance for the City and County of Honolulu, and for ILS, which was a private ambulance, and a technician at Queens, all at the same time, and found that I really enjoyed just being with people. The lab work I enjoyed, but I didn't enjoy it as much as being with people. So it just seemed like a natural evolution. I wanted to continue to go to school, and that work on the ambulance evolved into my career in medicine. I did work in the ER for 8 years, but my desire to just keep endlessly training, did that extra training in nephrology after internal medicine. And it's really been fulfilling. I enjoy taking care of people, not only in primary care, but helping them with their kidney. The kidney's interesting to me, talking to people about their urine and stuff like that. So that's it in a nutshell. But started military police, got diverted into combat medic.
Okay. How about Dr. Lyla and Dr. Hazel? Who wants to go first?
Who do you want to go first?
Okay. I'll just make it juicy. I'll just make it very interesting. Okay. So, what the public may or may not know, both your mothers are physicians, and both your fathers are community public figures. What do you say when some people assume you became a doctor because of them, and your successes in life and the patients you have are because of your parents? Go.
You first, Lyla.
Well, that's kind of easy because I didn't want to be a doctor for a long time, because my mom she worked really hard, right? And there's nothing wrong with hard work, but as a child, you see your mom working a lot and you don't get to spend time with her, or you spend a lot of time like with her getting called out of parties, or called out of the movies. I don't think we ever finished one movie with my mom there the whole time because she kept getting paged out. And I grew up pretty much in doctors' lounges and in the car doing my homework for hours while she rounded, or in lobbies of hospitals because my mom was a doctor. So that really made me not want to be a doctor, because I want to be a mom too, and I want to be able to see my kids and do a lot of things with them that my mom didn't get to do. But fortunately, because of my mom, she paved the way so that when it finally came on that I wanted to be a doctor, which didn't happen until I was already out of undergraduate and out of law school, when I decided to be a doctor. And it came because I was seeing patients in the clinic while I was in Honolulu looking for a job. And the patients, they were like always happy to see her and so thankful and grateful. And my mom made a lot of difference in their lives. And I wanted a job where I could make the same difference in people's lives. And does it mean that I don't see my family for a long time sometimes? Yes, it does mean that. But, you know, like, I feel like the reason I can do what I do is because I have an awesome family at home who knows I love them, and who, like, my husband is awesome. Hi, Shane. Hi, kids. And what y'all don't know is I'm actually on quarantine right now. So I haven't seen my family since Sunday. I'm not going to tell my patients to do something that I'm not going to do. I've been sleeping here in my office since then. But my family's been holding down the fort, and they know that it's important, and they know what I do is important, but that still doesn't take the place of their presence in my life. So I miss you guys. But anyway, when I talk about being a doctor is what I was called to do, because one day, you know, like, I literally woke up and I heard this voice that said,
"Oh no, you're sharing your God story."
No, my God, you'll be a doctor. And I'm like, that? But it wasn't. It was like, I woke up and I'm like, God, that was a really bad nightmare. I don't want to be a doctor. But I just thought about it, and I finally went back to school, and I realized I've always been good at science. I always really liked science, and this is what I wanted to do with my life. And I feel like the hard work that I have, yes, it is because a lot of it is because of the hard work my mom put in, but basically paving the way so that I could be the kind of mom that I want to be, because of the sacrifices she made as a doctor before me, whether it's just paving the way as a female physician or paving the way with building the clinic, so that when I came to be a doctor, here I am. However, like, we've grown the clinic together in the last 15 years, and initially her patients were my patients, but now they're my patients, and more patients are my patients alone that have come to me just because of the way I doctor them and the way I care for them. So I think my success, although built on the foundation of my parents, is my own, through my own hard work and through my own diligence in caring for the patients that I have.
Awesome. How about you, Hazel?
I'm just gonna say ditto to everything Lyla said. Everything nail on the head for me, except hers was law, mine was teacher. So I thought I was gonna become a doctor, and then in college I was like, is this really for me? So I delved a little bit away. It's like, okay, let me try this teaching thing. And then my heart pulled me back to science. It pulled me back to serving the way my mom did. And so I went back into the pre-med track, and very blessed and lucky that my mom has been, like, she's my biggest role model. She really is. She's the corner of my heart, right, always. And I'm gonna cry, but
don't cry. Oh yeah, cry.
You know, a lot of us Filipinos, our parents are immigrants, and so we saw a lot of their, like, struggles and sacrifices and multiple jobs, and, you know, they kept talking about immigrating for a better life, and here we are. You know, their dreams came true for them, but more for us, and here we are giving back to the community because of their struggles. And so,
okay, I can give you a tissue, but I don't have one for you.
A lot of people don't know that Hazel's mom worked in our office for a long time while she was trying to get into med school and residency program. And so, you know, she was doing that, and, you know, Auntie Beth was, like, putting in the work to get in there. But when she finally got into med school, she had to go to New Jersey to go to med school. but the kids were here. So Uncle Jun stayed here with the kids. So her sacrifice to be a doctor meant that she had to be away from her family for 3 or more years. That's a hard thing, but you know, when you're called to do something, it's like your life is not complete unless you complete that calling. And it takes a special spouse to be a doctor's spouse. It takes a special child to be a doctor's child to understand all that. And it takes a special family to be so supportive of your career. My mom right now, right? She's having such a hard time because she wants to work and she's high risk, right? So I won't let her work because I don't want her to get sick in the clinic. So
yeah, that was my question.
I don't want her to work because, you know, she is in that category where she needs to protect herself. And God forbid, like, how would I ever forgive myself when all the hard work that I put into be a doctor, I could have worked the whole time and mom has 0 exposure. You know, I'm not going to put her in a clinic in line of fire, basically, when I know she's high risk. So I'm doing more work now, but I'm loving it. And I know that the work that I'm doing is keeping my parents safe. And, you know, that's important to me because, you know, whatever I need to do to keep them safe is what I'm going to do.
You shared your motivations of why why we do this, you know, why we're doctors. But with the surge of COVID in our communities, we see our friends or other frontliners, we see the stress in healthcare workers. Has your outlook changed in terms of you wanting to be a doctor? Are we burning out? How do you guys feel right now?
You know, for me, we made adjustments in the clinic with the video and the telehealth to help protect not only me, but our staff and our patients from coming in. But I just feel so grateful to be able to work. If you work in a hotel right now, if you work for the airlines, many restaurants, through no fault of their own and no choice of their own, sometimes both spouses in the household are out of work, and it could be for a prolonged period of time. And so I'm just grateful to be able to do a job I enjoy, for people who are generally happy to see me. And so that's kind of how I feel. I felt a little stressed in the beginning about being in a room or in a hospital with COVID patients because I was worried for myself and my family. But now that I realized with the precautions that were pretty safe, not perfect, but pretty safe, I just have more empathy for a lot of other people rather than looking internally.
How about you guys? Dr. Hazel, Dr. Prather?
Has it diminished my desire to be a doctor? Not at all. I think that everybody has their own level for burnout, but I think that you have to know yourself and balance things out. I mean, you have to find things that when you know you're stressed out, you know, you got to do those other things. Like I have my Peloton in my office next to me. So when I'm really stressed out, I ride that, trying to keep healthy and try to get the burnout out. So the paperwork's always going to be there. You just kind of have to own that. But I think that, you know, the fact that I know that I'm helping people in this really hard time makes it worth it. You know, I don't think I'd be able to, I don't know what I'd do if I wasn't a doctor.
Hazel?
I think it's a great time to be in the medical field. I don't know how many people will get to experience living through an era like this that has impacted everyone's life so drastically. And to see the way medicine develops has been so much of a journey and so interesting to be a part of. And, you know, guidelines are constantly changing and we're constantly as physicians trying to keep up with the guidelines and the latest studies, and we're constantly trying to learn. So no, I definitely feel like COVID has not diminished my joy of being a physician. It's actually made it more exciting for me in a weird way. But yeah.
So from my aspect, I think our perspectives have changed over time, right? So when COVID hit back in March, everyone's freaking out. Like, oh my gosh, what is this? People are dying. Here's some news clip from New York and Italy. So everyone's freaked out about the whole thing, right? And everyone's freaked out about PPE and all these riots and things. But when we finally caught up with the PPE, when we finally caught up with some maybe good treatments and standards in the hospitals, I think everybody calmed down a little bit, where people's anxieties and fears are a little bit better. So I feel like in summertime, everyone got used to be in the, and saying in the hospital setting and also outpatient, you got used to knowing that some of your patients are going to have COVID and this floor and this room has COVID. But you feel more comfortable being protected with the mask and the face shield and walking around. And to the point where, like, you know, for us PMAH Board of Governors, we text each other all the time. What do we do if blah, 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 blah. So I think the communication between physicians has increased because now we ask input from each other, you know? And I feel like the awareness of mental health has increased and we are there for each other. So I know I'm friends with many COVID providers in the hospital, and, you know, at the end of the day, if they text me, I'm there to talk. I'm there for them to just decompress. And as the months and the weeks and months go on, there's going to be new challenges. But I think, you know, it's all about coping and being together and helping each other as a community and helping each other as a community of providers. And I think COVID has allowed us to do that. And COVID has allowed us to figure out technology. Like I figured out this Facebook Live thing, like when I first started a couple of weeks ago. You know, this is all new technology for us, and we have all these ideas, and a lot of people have these ideas. You know, so it's a resurgence of great things from just being at home and having to see the light a different way. So what do you guys tell people who are considering a career in medicine now? And I know, like, not a lot of places are taking shadowing opportunities or letting students in the hospitals, and some clinics are, but what do you tell those kids?
So part of Philippine Medical Association is we have a mission to mentor our pre-med youth who are desiring to become physicians. And so it's been very unfortunate to hear and see that a lot of them who were getting in-patient experience by shadowing physicians in the clinic or in the hospital basically were kicked out of all of these experience since COVID started. I personally had 2 pre-med students with me who want to become pediatricians, who are excited about following me in clinic. But then unfortunately with COVID, I had to say, you know, for your safety and for the safety of your family, you know, I can't have you here right now, but please come back when things are safer. So what I'm encouraging pre-meds out there, and what we have done with PMAH, is now it's time to get creative, to find other ways to get experience, help the community with what you know, with what you can, with what tools you have, which a lot of times is technology, and disseminating the important facts out there to your generation. So for the pre-meds out there, you know, don't give up, keep going, get creative, think outside the box. The traditional path has always been get a couple of shadowing experiences, get a couple community service, go do some research, get good grades, MCAT, and you're gold for getting into med school. But now with COVID, a lot of that has changed. And I'm pretty sure a lot of you, your personal statements are going to be really affected by COVID. So find new ways to get involved with the community. PMAH, we have a great group of pre-med students who are helping us find new projects to help get the word out on how to keep our community safer. But don't give up.
Great.
Yeah, I would totally encourage anyone who wants to become a doctor to do that. I mean, we're in more need of you now than ever. Our state is so short of physicians, and although it takes a long time to be a doctor, it's worth it. I mean, there's no other career that I would rather be in. And I think that it's important that you know that it is sacrifice and it is hard work, and you shouldn't do it if you want money, because some people say, oh, you're going to be a doctor because you make a lot of money. No, I mean, like, no money on earth is worth me being away from my family. But you know, like, if that's what you're called to do, you do it. Find people who will mentor you, will guide you, will give you good advice. Figure out how else you can be effective in this time when you're trying to learn about when you're trying to apply to schools, and don't give up. Basically, like Hazel said.
Great. Well, thank you for sharing your personal experiences. I think our brain kind of settled down a little bit. Got some tears out, family drama. It's a great show, great show. Okay, well, back to COVID. I have a bunch of questions from the audience I've collected in the past hour. It's already 4:40, so we're flying, okay? Do you think, number one, what symptoms should we worry about when we actually call the doctor? And yeah, so that's first question. When do we call you?
You call us when you feel sick, and then any kind of sick, really. COVID is like a great disguise. What is it? It's like lupus. What is it? The great impersonator. But it's like that. You don't know if you have COVID. You have no symptoms. You could be like in total respiratory failure. You could have a little runny nose. But definitely call us if you don't feel well. Call us if you have any kind of upper respiratory issues, diarrhea, fever. Call us for sure if you had a contact.
Mm-hmm. So for pediatrics, alluding to what I was saying earlier, if you have a child that's positive for COVID, what we really want to get called about is how's your child's hydration status? Are they able to keep down fluids? Are they constantly vomiting? How's their breathing? So back to the point earlier for the adult docs, they were saying, you know, pulse ox, the word where they check your oxygen level, and we worry if it's less than 93 or so. For pediatrics, we don't like to use a pulse ox. Really what we're using to determine your breathing is your child breathing fast? Are you seeing ribs? Can you see the baby's, over here, their clavicles? If your baby is breathing fast and you're seeing their belly go up and down and they're satting 99%, I still want to get called, because that child can just really quickly decompensate or get sick really fast. So please, 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 if your child is not keeping any fluids down, getting dehydrated, getting really sleepy, not moving, just looking what we call quote unquote lethargic, that's really scary for us. Or fast breathing despite normal oxygen levels. Call us fevers. A lot of parents don't worry about that stuff, but they worry about the number, the fevers. That actually doesn't freak us out as pediatricians. You can have 103s, 104s, and we'll say you're going to be fine. So just make sure you have a stack of Tylenol or ibuprofen at home. We actually don't want you to go to ER just for fevers. You might increase your exposure there. Every parent is capable of managing fevers at home. For our parents out there, fever is more than 100.4. Okay, 98 is normal, 99 is normal, 100 getting there, but still normal. So 100.4 is a fever. I get lots of calls saying, doctor, my child's having a fever. Well, what's the temperature? It's 99. So low grade fever for me is 100.4, 101, 102, 103 is okay, 104, and maybe a little bit excited, okay? But please don't worry about the numbers if your child is having a fever. Just call your pediatrician, don't run to the ER.
Yeah, and like I said before, a lot of people don't have pulse oxes, right? Or you can't get a hold of one. If you can't say three or four words at a time without taking breaths, if you sound like Dr. Prather, I really am having heart. If you sound like that, you need to call me. Okay.
And for clarification, this is for COVID and non-COVID patients.
And non-COVID. If you're asthmatic, if you're a kid down the street, all of a sudden you can't breathe, call your doctor, call the emergency room.
Okay, thank you. Can somebody explain what herd immunity is with the resurgence of all these community cases? Are we going to get herd immunity now? Who wants to take that?
It really depends, because this virus is so young. We don't know what it's going to do, right? So theoretically, if it stays the same or only has minimal changes, we could get herd immunity.
Can you explain what that is?
Herd immunity is when enough people have been exposed to a vector, which is like an infection, that now everybody builds antibodies and is now immune to it should they get exposed again. So if like vaccines can give you immunity like that because it introduces the vector, so you can make antibodies against it should you get exposed again. But with COVID, we don't know, because natural immunity, some people say, like, can we get a COVID infection again? I know people are wondering about that. It really depends. Like, we're seeing people not getting COVID again now. Our first case was in Nevada, where a person got COVID 6 weeks after they had COVID, but it was a different strain of COVID. So, but in general, in the first 3 months, hopefully you have built enough antibodies. So if there's only one type of COVID in your community, you're going to be okay. After 3 months, we don't know, because that's generally when your own antibodies taper down, which is why a vaccine is so important. Do you all agree, or Jim, what do you think?
Yeah, I mean, you get herd immunity two ways, as you alluded to. Either a lot of people get the infection, which is something that has a death rate as high as COVID, and not that it's that high, but it's high enough that we would have, if we let this, if most models that I've looked at, that other people have made, that I believe that if we were to let this run through the state of Hawaii unchecked, let everybody get infected that we could, we would have 5,000 deaths. And yet now something like 70 or 80 deaths, and still a lot, which is, you know, and people try to compare this to flu and say, well, last year we had something like 500 flu deaths, but it, you know, we only had 50 COVID deaths or whatever it was. But what I think I have to remember, and people need to remember, is we had, and I don't, forgive me for not knowing what the latest death count is, but it's somewhere, I think, around 70. But we've had that many deaths with tons of restrictions. We had the 500 deaths last year with no restrictions. So if we were just to let COVID just go loose, eventually we would get herd immunity, meaning enough people would get infected that it would quit spreading because everybody would have antibodies. However, to get there, we need, you know, unfortunately, 5,000 people would probably die. That's the estimate. It's a lot of people. And that's not including all the people that would die because they couldn't get a hospital bed.
Right.
With all the COVIDs, patients in the hospitals, there'd be no room for the heart attacks and the pneumonias and the stroke patients and everything else the hospital needs to take care of. So a much better way to get herd immunity in a deadly disease is through vaccination. And so if enough people in the community get a vaccination and a couple don't because they don't want to, or religious reasons, or they're scared of side effects, then, you know, they would still be protected because 90% or 70% or whatever of the rest of the population has protection, and it won't jump from person to person. So herd immunity is a goal, but we need, I think, to get there in a safe way through vaccines.
Okay, great. I have a long question. I'm just going to read it. Seems that some COVID patients are now discussing additional symptoms they are experiencing, such as depression, loss of hair. They seem to get better with manageable symptoms, but then bam, the patient takes a turn for the worse. As this disease matures or we become more aware it's not just a disease with flu-like symptoms, how do you keep up to date with the various possibilities of symptoms that are now showing up? Are there COVID provider specialists? See if you guys can comment on this question.
I'll just jump in real quick. There's a syndrome that's got just a loose name called the long haulers. And when someone first mentioned to me the long haulers, I thought they meant long haul truckers. Or long liners, which is the guys who reel in the tuna with all the fish hooks. But this syndrome of the long haulers is just what the writer of the question alluded to. There's these odd lingering symptoms way beyond the acute illness. And it reminds me of a mixture of like fibromyalgia, where there's chronic pain, joint problems, mental health issues, not feeling clear, depression. And this disease is so new that just I'm having to learn about these things from other physicians in the mainland who've seen now this disease more than we have. Because really in Hawaii, we've got about a 3-month history with this disease, New York and some of the other places more. But it's real and it's been described. But until more cases come out, and it's good that there aren't that many cases of this, we have to learn from the literature or the medical reports, because there are no COVID specialists. And to be honest, the people who are going to know about this disease the most are people who see it in their primary care clinics. for adults, because that's who mostly get it. So it'd be Dr. Prather.
And I wanted to add, you know, COVID has affected not just the respiratory system, like your lungs. It also, you know, gives you some GI tract, some diarrhea, constipation, those type of stuff. But the mental health impact that has made for everybody is a lot, right? You just increased stress, increased depression, increased suicides, increased just like you're just angry at home, increased sadness. So this is real. This is real for everybody, no matter if you're in the, you know, healthcare system or not. And I feel like we have to learn how to cope with such things, with the depression and anxiety, because if you kind of just let it ball up inside, that's when patients and people in general get more sick, right? The depression will take over your body. The sadness will take over your body. And that can, something that can kill you. So something very, very, very important that to realize. Okay.
Can I just add a little bit? So a lot of the young adults actually make up 50% of the cases in Hawaii with COVID. So ages 18 to 30s, half of COVID is the young adults. And a lot of them are a little bit looser with the social practices. There's a lot of thoughts out there, such as, even if I get COVID, it's just gonna be a small cold, I'll be fine, I'll recover. But going back to what Dr. Allen was saying about this long haul, you know, even as a young adult, if you get COVID, there's still that chance that you can have lingering symptoms that will last weeks and weeks. So for example, I have a cousin who has COVID. She's very healthy, 30s. She's finished her quarantine for 10 days, but she's been out for about 2-3 weeks now. And she's like, I still can't go back to work. I still get very short of breath. I feel very tired all the time. I have this really bad headache. So I want the young adult population to know that if you do get COVID, there's also this prolonged symptoms where you can't go back to work right away, even if you think you just need to quarantine for 10 days. So this is very real.
What are you guys' opinions on the stay-at-home order? Will they be extending this? Controversial topic.
From a doctor's point of view, I hope so. Okay. But I know it's really hard on the economy. The important thing is to figure out how are we going to open up in a safe way. You know, if you just look at the health aspect, it makes sense to stay home, but you can't just look at that. You have to look at the economic impact on the family, the mental health issues of staying home, for the children too, not being able to socialize. And you have to really weigh that. The easy thing to say is yes, but the hard thing to figure out is how are we going to do it safely?
I think opening up is going to really depend on what's happening with the hospital system. A big reason why we closed again most recently was because we were seeing surges in the amounts of COVID cases in the hospital, where we were so worried that we were going to start having unnecessary deaths from people who are, just like what Dr. Island was saying, people who have heart attacks, pneumonias, they weren't going to have space in the hospital. So we were trying to prevent that. And that's where Hawaii was going towards. But now that we've seen this stabilization, and now that we know that if we can start seeing a decrease in the amount of COVID cases in the hospital, where we now do have room for all of these other people with other conditions, that if they need medical care too, there is going to be support for them. And I think that'll be a safer time to open up, but we're not quite there yet. So I think a lot of when we're going to open up in Hawaii's economy has to do with what's happening in the hospitals.
You know, I'd like to just pose a question to Hazel. What do you think about the schools, and do you think, when do you think they should be open now, or when do you think they should open up?
So I have a lot of feelings about schools.
Me too.
Yeah, I mean, you know, I understand the need to keep our kids home because we understand that they're just big dishes of viruses. They touch, and, you know, they get sick. Whenever I have a 5-year-old that's starting kindergarten for the first time, I tell parents, look, they're going to get sick twice a month for 1 year, and it's going to last maybe 2 or 3 years because they're building an immune system and they just don't know how to keep their hands to themselves and wash their hands. So now we have COVID on top of that. I worry about them getting it, having a mild symptom, maybe being asymptomatic, because 40% of these kids are, and then bringing it home to the parents. So the kids themselves, I'm not too worried about. It's them bringing it home to their grandma, their grandpa, someone that has comorbidities, or getting it from home and then giving it to their teacher who also has comorbidities. So I was initially very anxious about that. But now that I see that some schools are opening up again, as long as the schools feels like they are able to do the social distancing, the 6 feet apart, hand washing, masking, and practicing all that social stuff at school, I think it's safe. But it's a matter of can the school do that, especially at a certain age. I cannot imagine trying to keep a 5-year-old in their seat for an hour.
And what do you think about? And I've talked to lots of different people on lots of different aspects of this. What do you think about having all the students and the staff at the school get a not the deep nasopharyngeal swab that's a little invasive, but maybe a benign shallow nasal swab once a week or every other week?
That's the first time I've heard about that. But then COVID changes so fast. Right? Like you could have one person that's healthy on Monday, and then by Thursday, they could be having COVID and symptomatic because they were exposed to someone when they got home after Monday. So once a week, I feel like with the way COVID has evolved, just when watching it in the past 4 weeks and how things change so quickly, I'm not too keen on that idea once a week. Maybe for the older kids who are better at practicing social distancing, that would work. Like 4th grade and up, but for the younger ones, I'm still a little bit worried about them.
I think from a parent's point of view, I wish that the schools would just say, we're going to do online distancing until December. And then we're going to really think about how we're going to open up really well in October. Because it's driving me a little bit bananas that it's like, well, maybe next week. How is the parent supposed to plan for that? You know, like, okay, I'm going to get this provider for my kid. Oh, wait, I don't need you now. Oh, wait, I do need you. You know, I just knock it out. Just say we're not going to open till January and just do that and do the best that you can at it as a school administrator. Do the best as you can as a student. Do the best as a parent to support that. And hopefully we can get a good plan, not a sudden plan, to get back into school and on campus in January.
Okay. All right, well, we are almost out of time. I'm gonna go one by one. Anything else you wanted to add to let our community know? What's one thing you want our community to know or community leaders want to know? Okay, let's start with Dr. Abinsay.
So for me as pediatricians, please bring your children in for their vaccines. Please don't be afraid to come in. Vaccines are super important. Babies that were born in February, I didn't see until maybe like July. So they were so behind in their vaccines, but it was still safe for them to come in. So please keep up with your vaccines, talking to your doctor. And in general, with COVID, I definitely think that Hawaii can beat it. I do think that we can open up our economy safely again. And then the sooner that we all get on the same page with all this some people say masks don't work. Some people say this and that. But really science and studies have shown that it does work. And if we want our economy to open up sooner, please, let's all band together. No social gatherings with people outside of your home. And I'm speaking to my Filipino families out there. And I know we love to go to each other's houses and celebrate parties and just visit each other. I know it's part of our culture to even just go and say hi. But, you know, like I said, that one person that you are so comfortable with, you don't know what they've been exposed to. They could be an asymptomatic carrier. It's this big effect when one gets COVID. So now is not the time to be doing anything like that. Please, please, please. There will be a time to do it again in the future. But FaceTime each other all you want, call each other all you want, send pictures all you want. But that's my big message to our community.
Thank you. Dr. Ireland?
You know, I'll just keep it short for once and just thank you, Dr. Vera, for having me. This was my first Facebook Live, and I enjoyed it. And thanks to my other guests. So thank you. And I think the messages that I've mentioned and the others I've mentioned throughout the podcast just kind of hold and yeah.
Okay, Lyla?
For me, I think the most important thing is not to underestimate this virus. Just assume everybody has COVID. If you don't want to get it, if you want to pass it, assume everybody has COVID, including yourself. So if you think like that, then you're going to go ahead and do the things that you need to do to prevent from spreading it or prevent from getting it. I think we're going to have to do that for a long time and just, kind of got to take the hit so that one day we can open it again.
Great.
So thank you to all of you who are doing that.
Okay, so that wraps up our event for this evening. It is 5 o'clock, 5:01 actually. Thank you for a very informative session, Doctors Prather, Abinsay, and Dr. Ireland. To all of you at home watching and taking the time out of your 2 hours on your Saturday, which you should be home anyway watching. So mahalo, salamat, agamanak. Thank you for being here. And we hope that we gave you a picture of what's going on, not just in the hospital, but also outside the hospital. And hopefully we have empowered you to take care of yourself. Take care of yourself for yourself, your family, and your community. Visit us on PMAH website, pmah-hawaii.org. We are also on Facebook, Instagram, and YouTube, which has a lot of PSAs in different languages. Also, I have to do a special shout out real quick. The Filipino Complete Count U.S. Census. I'm wearing your shirt, okay? We're wearing your census. Ethnic Education of Hawaii, Philippine Council of Honolulu, Filipino Chamber of Commerce, Young Filipino Network, Junior Chamber of Hawaii, Olelo, ATI TV, Hawaii Use Now, JABSOM, PMSAH, and Hawaii Pacific Health, and also Queens Health Systems for supporting us in all our endeavors. Until our next talk, maybe in the next month or so, or we'll see, please visit us, and we will, for those questions that weren't answered on this event, we will get to you on our Facebook chat. Thank you again, and have a great, safe, long quarantine weekend. Bye-bye.
Wear your mask.